Hi, everyone. Good evening. Thank you, Nita, for the introduction. Today, I'll be talking to you about my work in predicting clinical response to acupuncture and placebo in treating chronic low back pain. We will be briefly talking about the background on chronic low back pain, outline the unmet needs in improving treating chronic back pain, and then describe the methods, approach, and results of my studies. And then we'll summarize and provide some future outlook. So chronic low back pain, what is it? It happens to most of us. It's the pain between 12th rib and the gluteal folds, and it's present for at least half a day in the last 6 months, according to the National Institute of Health Task Force on Research Methods, Research Standards for Chronic Low Back Pain. It has to be present for at least half a day for at least 6 months. It is a highly burdensome disease because, so why? Epidemiology. So about half of us at some point in our lives, we experience back pain. However, most of these pain move on to resolve. About 20%, however, becomes chronic, which accounts for about 8 to 10% of the population. So with that, chronic low back pain actually remains the number one cause of disability globally and in the US for many, many years. It outshines diabetes, heart disease, cancer, anemia, depression, migraines, you name it. That's the number one cause for disability globally. And it's also very costly, over $100 billion per year in the US alone. In fact, for the year 2017, it's $145 billion to be precise, due to lost work days and high medical costs and bills. So as a pain physician, I want to tell you the current landscape on how we manage chronic low back pain, just to prepare you so you can see where acupuncture fits in. So chronic low back pain, the most important recommendation from the American College of Physicians is non-pharmacological behavioral interventions. The most important is multidisciplinary rehab, followed by, so these include a combination of psychological interventions and physiotherapy. Other things such as exercise, acupuncture notes here, and MBSR, and they are highly recommended based on the ACP recommendations with moderate quality evidence. Other less well-known exercises such as Tai Chi, yoga, relaxation, biofeedback, CBT alone, and chiropractic, they have lower quality evidence, but they're still recommended. So the second tier of recommendations, if these interventions don't work, we move on to the second tier, including medications. The first line is non-steroidal anti-inflammatories. The second line is duloxetine, which has the only medication which has good clinical trial evidence supporting its efficacy in back pain. And the third line is opioids, last resort, and case by case only. And finally, there's invasive therapies such as medial branch block, surgery, etc., etc. This is really the last resort, and the evidence is moderate at best, and recommendations weak. So this is pretty much the landscape. So even with the most advanced therapies such as fusion and spinal cord stimulation, there's still big problems with the treatment efficacy and sustainability of low back pain. And so what are the main problems with low back pain treatment? The main challenge is that, number one, very small treatment effects, about 2 out of 10 numerical rating scale, or even less on functional rating scale. And these actually don't even meet the clinically significant criteria for pain symptom changes. So these actually are the actual effects from things like medications. I'll show you a little bit later. Even multidisciplinary rehabilitation and even fusion surgeries, same stuff. And if you look at CBT alone, it's even smaller. Responder rate is also not to write home about, and less than 50%. That's reflected by a high numbers needed to treat for medications and interventions. Usually it's at least a 3 or 5, typically above 10. And also, even with these mountain management, such as blocks, interventions, and medications, a lot of adverse effects happens, such as addiction, medication dependence, as well as surgical complications. The proposed solutions by the NIH and CMS include, again, high quality, low cost, multidisciplinary care as main focus, strong caution with surgical intervention approaches, and innovative therapies. These include newer ones such as fancy peripheral nerve stimulation, neuromodulation devices, as well as ancient therapies which are with renewed interest, such as acupuncture. Before I tell you more about acupuncture, I want to give an example of treatment challenges involved in chronic low back pain. As I mentioned, one of the star treatment we use in the clinic is duloxetine, aka Cymbalta, a classic antidepressant. However, even with Cymbalta, it has multiple clinical trials, its treatment effect is actually very small compared to placebo. As you can see here on a 10-point scale, the placebo reduced pain by 1.5, and real treatment was by 2.5. So the difference is only about 1 point out of a 10-point scale. And typically a 3-point scale is needed, 3 out of 10 is needed to, a 2 point out of 10 is needed to be clinically significant, okay? So it's really not even clinically significant change. It's pretty small change after months of therapy, and there's also adverse effects, right? So that's actually one of the better evidence we have is duloxetine. Now, what can we do to improve that? So here's what we did. If you stratify patients based on individual characteristics, such as early response to the medication, such as number of pain sites reported as having pain, aka widespread painness, these can improve the treatment response rate by 3 or 1.2 folds significantly. So we're going to basically take the same approach to acupuncture. So let me tell you more about acupuncture. We talked about innovations with treatment solutions, right? So why acupuncture? And what is it? So acupuncture involves putting needles on the body in specific meridians. We like it because it's minimally invasive. It's the biggest needle is like 40 gauge compared to the smallest needle in Western care, which are 30 gauge, which is the smallest one, hypodermic needle, right? So it's very small, low risk, not too painful, low cost, minimally invasive, and is tested, time tested. The earliest evidence of acupuncture dates back to 5,000 years ago. It's been used for 5,000 years. So this is the Yellow Emperor, who was supposedly one of the earlier supporters of acupuncture and Chinese medicine. So the book supposedly written about his work is the Yellow Emperor's Internal Canon, classic textbook for TCM practitioners. So the role of acupuncture in treating chronic low back pain. Now we know what it is. Does it actually help? So accumulating evidence shows that it does help with chronic low back pain. The first one was a large 17,000 individual level meta-analysis on pain, including low back pain, that showed compared to sham controls, the standard treatment effect is actually 0.2 to 0.5 of a standard mean difference or standard deviation. So it's pretty good. And then based on that, American College of Physicians recommendation from 2017 recommended acupuncture, as I showed you earlier, but they quoted the standard mean difference of or effect size of almost 1, because that's compared to usual care, i.e. 10 sessions of PT and any oral medications short of opiates. So these are helpful, right? So because of these recent evidence, Medicare and CMS have finally decided we're lacking just, 10 years behind European countries and many years behind Asia. So finally in January 2020, last year, Medicare decided to cover acupuncture only for one condition. And what condition is that? Chronic low back pain. So, and that was published in JAMA and Forbes. So now it's all in good. Acupuncture can be helpful for low back pain. So what is the issue, you would ask? So the issue is that very similar outcome between real and sham treatment. Like you can see here, the yellow and green is real, blue is sham. Candy cane is usual care meds and PT. So as you can see here, that minimal difference between real and sham and that the response rate, even for the sham and real, 60% only. And for the American study here, similar time, the response was even lower, about 40 to 50%. So only about 40 to 60% people respond to acupuncture or placebo. So half the people wouldn't respond. Wouldn't that be nice if we can capture them? So here is our unmet need number one, which is very important, not only for acupuncture, but for all other pain treatment, is to identify the responders. Because why? Similar efficacy between real and sham treatment in acupuncture. And if we can capture the treatment response prediction, the treatment response heterogeneity may be explained by patient differences, which may explain the limited effect size, i.e., in certain patients, there may be a huge difference between real and sham response, which is having to capture them. If we can capture specific responders to real acupuncture, we will then save cost, improve patient outcome, and improve insurance coverage. Unfortunately, currently, our knowledge on who responds to real acupuncture remains limited because most previous large studies focus on effect size and efficacy and effectiveness with only basic parameters collected, such as demographics, baseline pain condition, pain intensity. And they can explain no more than 5% of the variance in pain outcomes. So for the two existing studies where they use prediction modeling, they use very much advanced characterization techniques such as functional MRI cost $3,000 to $5,000 per session, and genetics, which are also very expensive, they involve full genomic and PCR analyses. So the need then becomes clear. We need to accurately predict outcome to acupuncture using pragmatic, clinical feasible methods. So how do we achieve that? So this is a brief a preview for what I did, what I'll be teaching you a little bit later. So we combined Eastern and Western approach, which is very unique. We borrowed from Eastern literature where we found demographics, baseline pain expectations, all contributed to outcome, about 5% variance. Newer studies from the last 3 to 5 years showed some Eastern Chinese medicine diagnoses may also predict outcomes in other conditions such as rheumatoid arthritis and hot flashes. We think that may make a difference in back pain as well. On the other hand, there's volumes and volumes of studies in modern pain management that showed the biopsychosocial model. It's a way of conceptualizing pain as a result of biological, psychological, and social factors. Therefore, treatment prediction and treatment and response prediction is also based on these three factors, have been well studied. So bio refers to quantitative sensory testing, aka QST, vital signs labs, specific pain factors. Psycho involves cognitive emotional factors, perceptions, expectations, and social demographics and roles. So extensive studies have shown that the biopsychosocial predictors can reasonably be associated with outcomes in chronic low back pain. However, still not a whole lot of prediction modeling was done specifically. So our goal is to combine these. Now, I want to also teach you a little bit more in terms of some of you who are not familiar with Chinese medicine may ask, so Jiang-Ti, what is the traditional Chinese medicine diagnosis framework? So here they are. TCM can be taught in two conceptual frames, one in terms of static balance and two in terms of dynamic movement. So the balance refers to yin and yang balance and more extensively the 5-element balance. The idea the ancient Chinese correlated their body structures with metaphysical objects in the environment. For example, the wood corresponds to liver and gallbladder in terms of organs, and then it corresponds to muscle movements, organization, vision, and assertiveness. And similarly, realize movement, right? And similarly, earth corresponds to stomach and spleen, digestive process, nourishment, comfort, containment, adaptability, stability, and empathy. And so in Chinese medicine framework, these 5 elements, wood, fire, earth, metal, and water, they have to be in balance for a person to be healthy. If they're out of balance, for example, there's liver stagnation or deficiency in energy in kidney, the most important energy meridian, or a spleen, then problems can happen. such as pain and chronic disease. Similarly, the other concept, which is parallel to the static idea, is the dynamic idea of movement. So what moves and where does it move? So qi is a concept of energy. Think of qi as a moving energy, and it moves along the meridian or channels on the body. The meridians are external manifestations of these organs, internal organs. So each organ corresponds to a pair of meridians. So we have a total of 12 meridians, and they correspond to these organs, and the free and comfortable flow of qi or energy in these meridians contribute to health, and their stagnation or obstruction can cause pain or other conditions or disease state. So that's about unmet need one, predict outcome to acupuncture using Eastern Western diagnoses. Now the unmet need two is how to predict outcome to placebo. So why do we care about placebo effect? Because it's common in not only acupuncture, but also pain and depression and psychological trials. The effect size of placebo approach that of a real treatment, and therefore, as clinicians, we want to optimize that and amplify it, use it to our advantage, to identify models to predict to placebo will help us understand its mechanism and optimize its use. And CARE status, so we know actually there's a large body of literature in pain and neurology on placebo effect. It mostly has two components: expectation and Pavlovian conditioning. It involves primarily brain structures, both supratentorial, prefrontal limbic, as well as infratentorial, the endogenous opioid pathways, primarily the peri-aqueductal gray from the brainstem. Current predictions, again, use advanced methods, including genetics and functional MRI, with moderate success, again, like the acupuncture study, R-square about 30% variance of the outcome. So that's the landscape. So how are we going to do things differently? So here we already would, the way we would tackle predicting outcome to placebo is going to be similar to acupuncture, because we have randomized controlled trials with placebo arm. We use the same broad based on characterization, multidimensional, but similarly also pragmatic without advanced characterization. So here's a problem, as I outlined before: how to predict pragmatically outcome to acupuncture and placebo in chronic low back pain. So here's our approach. One, multi-dimensional characterization using Eastern and Western approach. We talked about a chronic pain literature, biopsychosocial, and Eastern literature, acupuncture, comprehensive demographics, and TCM, or traditional Chinese medicine diagnoses. And the same approach applies to also the sham or placebo arm. And machine learning. So now we have about 62 predictors. How do we figure out which one will be important predictors? So here's where statistics comes into play. Machine learning is where you use the machine to do computations to pick out the best parameters. We picked lasso because it's fairly simple. It performs both variable selection and shrinkage. It's a regression method. It minimizes overfitting and picks out usually fairly simple models to help you predict outcome, which are also interpretable. And last but not least, the most important part is that lots of existing studies in both acupuncture and in placebo, they just validate within the same population, but that's not true validation. For true validation, you need an external validation. So we actually have that. We have two independent studies. So how do we achieve that? We actually, my mentor, Dr. Mackey, and I, we led two different trials. He had an NIH center trial, and I have a training study. So these two trials, they both study electroacupuncture in treating chronic low back pain with different focuses. But luckily, they have similar designs, both randomized, placebo-controlled, and blinded, and they have identical treatments and similar outcome sets. So here's more details. The model building set, which was first done by my mentor, Dr. Mackey, about 100 patients, moderate to low back pain, used real or sham or placebo acupuncture. They have two outcomes: function, which is the RMDQ, and pain, which is the NIH Promise Pain Interference. It's a scale, and we have 62 predictors, the same design for my study, which took place 2 years later. We have the same everything except for we had a different set of, we have more predictors for a different set of study, but we also have similar outcomes and shorter treatment, 6 versus 8 weeks because of budget limitations. Yeah, so the T-score, sorry. So for pain interference, it's a T-score. RMDQ is a raw score. All right, so in terms of model building, we have 4 models per total built from study 1, Dr. Mackey's study, where we have 2 models for each arm, 2 for real and 2 for sham placebo. 1 for each of the outcome, 1 for function and 1 for pain. So each model is built on 50 participants with 1,000-fold internal validation, bootstrapping. And then after we fine-tune these models, we apply these models to the patients from study 2 who are completely independent, different team of recruitment and different patients. So we estimated the change in pain and function each arm. So 2 pain, right? Pain in real, pain in sham, and function in real and function in sham. So 4 outcomes, and we assess the performance of prediction using both regression, correlations between the outcomes predicted and actual, and classification outcome. We use well-validated cutoffs for pain and function, and we assess area under the curve, which is the receiver operating characteristic curve. So here are the results. So first is an outline of our study. As you can see, 2 studies, they're quite similar. Sample size of about 100. They're independent. There's some slight differences. For example, study 2 had higher baseline RMDQ, meaning more dysfunction at baseline compared to study 1. They're also older, 46 compared to 41 years old on mean age. And furthermore, in study 2, we found statistically significant treatment effect in both RMDQ function and pain. And we reported that in our JAMA article published just last year. Dr. Randy Stafford and also Dr. Mackey both on this paper. So this is kind of real life. We will see that you will see external validation, but the studies cannot always be 100% aligned. There will be some minor differences. The question becomes, can you use models developed on the first study on the second study? And the answer is yes. So here's the results. I'll take your attention strictly to the bottom here. So on the left-hand side are the variables. The gray bar here separates baseline variables from initial response within 2 weeks variables. Here are the outcome performance. So here we have prediction of pain outcome in the real and sham, prediction in the RMDQ in the real and sham. And you can see here we have very nicely performing models with AUC of approaching 90% in real, 73% in sham, and good correlation numbers for pain, and moderately good for function. And the next part, so there are some area under curve performance measures. And then we ask our next question. In the first model, we used early treatment response. The question that we asked was, can we use just baseline predictors, no early treatment response? And the answer is yes. Mostly, we could predict, again, outcome to pain reduction, but we failed to predict outcome in real treatment functional improvement in our machine learning model. But still, for the pain reduction, we had excellent performance, again, for placebo and good performance for real treatments. So you can see we have captured variables, both TCM diagnosis stagnation and widespread pain. SET stands for expectations, house income, previous opioid exposure, and smoking. Here's a ROC curve. So I want to compare our outcome to existing best studies. So the best study so far was actually a Harvard study in predicting acupuncture outcome. So when we were awarded the Center 12 to Dr. Mackey, our friends from Harvard were awarded same money. So they did study, they used exclusively functional MRI, advanced imaging, functional connectivity in the brain, multiple levels, machine learning and everything. But because of the use expensive characterization and takes a long time, they could only perform study on 50 participants. And they have found, using their internal cross-validation, they could predict R-squared 34%, P of 0.03, which is quite good. So in our work, we had N of 100 on as validation. On the model building was 99, and we reached R-squared less good, about half of that, but highly significant. But notice that we use very inexpensive treatment, assessment, just simple sensory testing and brief questionnaires, which takes less than half an hour to finish. And also note that we used external validation, and the other one is only internal validation, which runs the risk of overestimating the model. So looking at the placebo outcome, this is a Nature article by a colleague from Northwestern. Using both functional MRI and questionnaires, they reached R-squared 0.36, whereas for us, simple sensory testing and questionnaires, we reached R-squared 44% and much more significant. So that shows we actually outperformed advanced studies. So in summary, for the first time, we developed and externally validated prediction models for response in treating back pain using acupuncture and placebo. And our models revealed differential mechanisms for acupuncture versus placebo. Although both involve positive expectations, which improve response, the sham or the placebo treatment is determined by anger, trauma in childhood, and fear avoidance beliefs, whereas for acupuncture treatment, TCM diagnosis plays a key role, and other factors such as opioid exposure, smoking, and widespread pain also play an important role. The significance is that our study demonstrated for the first time that we can predict outcome to acupuncture using clinical and behavioral variables only, and our results for placebo prediction outperform existing studies with advanced categorization, revealing exciting possibilities of understanding placebo mechanisms. We also demonstrate it's possible to potentially stratify patients based on individual characteristics that are easily measurable in clinics. And our examples finally combined Eastern and Western medical research. Limitations: we can improve the performance of the VIRM or the real acupuncture model by using additional predictors and refined TCM diagnoses. We could also further characterize each individual predictor by their relative weight and statistical significance on their own. And finally, we should validate our existing models in other pain treatments as well as other pain conditions. Finally, I want to thank you for your attention. I have a large number of groups and individuals to thank, and they're listed right here. I'm ready for questions. Thank you very much.